So, very good morning to everybody, and it's a great pleasure to be here online for this focused meeting on manometry. So, I am Dr. Srihari. I bring greetings from Sir Gangaram Hospital, and I was just discussing with Narayanan that what should be the theme of this lecture, and he said that at PSG, manometry is already being done since last 8-10 years, and there is a mix of residents and faculty. So I've tried to keep this talk including both the basics as well as a little bit of nuances and some deeper insights into esophageal motility disorders and the role of manometry. In the next 25 minutes or so, I shall be discussing that, and I would encourage if there are any questions that can be asked freely. So basically, when we talk of motor disorders, usually the first test that we all do for any kind of dysphagia is an endoscopy. But when patient comes with a non-obstructive dysphagia and you do an endoscopy, several times you might not pick up anything major. And we have come across so many cases with a endoscopy being reported normal, even by the most experienced of gastroenterologists. So I think it is important that we all realize that any patient who comes with non-obstructive dysphagia, don't rely on your endoscopic diagnosis always. There are very subtle findings that we tend to miss. And this was a clear case when on the endoscopy you feel you are absolutely not seeing any major pathology. But when you do a manometry, this was a case of achalasia cardia. This is an actual case that I'm showing you. Okay, this is especially true for patients who have low IRP achalasias, and that's a fairly common entity in clinical practice. So, what high resolution manometry does is that, as for anatomy, you have an endoscopy. For motility, so when we talk of the esophagus or we talk of the anorectum, these are organs which have a lot of physiology to them, not just anatomy. So for the physiology, you have this modality called manometry, which helps in evaluating the motor function, the physiological motor function of these organs, right? So manometry is present in two forms in the market. You have the water perfusion system and you have the solid state system. Predominantly in this country, as of now, we have the water perfusion systems. I think more than 90% of the installations are water perfusion. And some of the centers, especially now, have started moving on to solid state systems. Okay. So if you talk of a water perfusion system, so basically every water perfusion system will have some water containing chamber in their system, and this water is being propelled under a certain pressure through a system of capillaries. There is a complex system of capillaries in the machine, and through this system of capillaries, it's all connected to a single catheter. And this catheter has several channels to it. And the water is dripping at a constant rate, at a prefixed rate through all the channels. So it is the resistance to the flow of water at the different channels that we are trying to estimate. Okay, so the basic principle is the water is dripping through the various channels, and the resistance to the flow of water is what we are trying to see in our areas of interest, right? So if you have put a catheter in the esophagus like this, and because we know that esophagus is a peristaltic organ, you would see a wave of peristalsis that is going from the top to bottom. Okay, previously the manometry was done in the form of line graphs, and this was how a typical line graph would appear, a high pressure wave starting from the top going down to the bottom. Okay, but in the body, things are happening in three dimensions. So actually, what is happening is something like this. This is a three-dimensional peristaltic wave, which is starting from the upper esophagus going down to the lower esophagus. Okay. But whenever we have to see something in three dimensions on a two-dimensional screen, our monitors are two dimensions. So how do you change a three-dimensional structure to a two-dimensional structure? So the researchers, especially Dr. Ray Claus, so he was the one who proposed that we convert this into the form of colors. Okay, so this is a contour graph. So this is a Claus plot. So what basically they did was they gave different colors to the different pressures. Okay, so in any manometry, you will see a spectrum of different colors, right? So you have the warm colors and you have the cool colors. The warm colors usually are the pinks, reds, maroons, blacks, etc. And the cooler colors are the blues, greens, yellows, etc. So in the graph, in areas where you see the warmer colors are those areas which have high pressure, and those areas where you see the cooler colors are the areas with lower pressure. Okay, so like in this graph, you see a high pressure zone at the top, you see a fairly high pressure zone at the bottom, and you see a high pressure zone going from top to the bottom like this, right? So basically this is the upper sphincter. So in body, all the sphincters at rest are usually in a state of contraction. Okay, so the upper sphincter is in a contracted state, the lower sphincter is in a contracted state until when the peristalsis comes down like this, and this is the esophageal peristaltic wave, which obviously is generating a high pressure wave starting from top to bottom, right? So this is the basic principle of a manometry. Okay, so where do you use esophageal manometry? We use esophageal manometry for evaluation of motor dysphagia. One of the very important indications again is for evaluation of non-cardiac chest pain. We have so many patients who keep coming back and again for recurrent chest pain, and you have done an extensive cardiac evaluation. It all turns out to be normal. There is a very strong likelihood that these patients are suffering from esophageal motility disorders. And one of the very important indications also is for evaluation of gastroesophageal reflux disease. This is one of the areas where manometry is underutilized. Two indications here. One is for placement of the pH electrodes. So whenever you're doing a 24-hour pH study, to evaluate where you have to place those electrodes, a manometry is a must. You can't depend on the endoscopy. Why you can't? That I'll come to that. Why you can't depend on the fluoroscopy? I'll come to that. And also for pre-operative evaluation of an anti-reflux procedure. So if you have a patient with GRD where you are planning to do an interventional therapy, a manometry is essential. Okay, so why? I'll again come to that. So a normal esophageal manometric plot will appear something like this. You have a high pressure zone at the top. This is the upper sphincter. You have the high pressure zone at the bottom. This is the lower sphincter, and you have a peristaltic wave like this. Okay. So when we analyze a manometry, there are some very basic things that we need to know. There are not many parameters that we need to know, some very basic ones. Okay. So there are a few landmarks that you should identify. The first important landmark that you have to identify is the anatomical sphincters. Okay, you have the upper esophageal sphincter and you have the lower esophageal sphincter. So these sphincters are usually easily visualized as I showed you in the previous graph. So sphincters are characterized by abrupt changes in pressure. So you'll see them as a high pressure zone, and the pressures will go down when the patient is swallowing. Okay. So like in this case, you see the high pressure zone at the top. This is the upper sphincter. You see the high pressure zone at the bottom. This is the lower sphincter. When the patient has initiated the swallow, there will be a break in the upper sphincter. And when the swallow reaches, the peristalsis reaches the bottom, the lower esophageal sphincter is again relaxing. Okay. So these are the sphincters. Then comes something called as the transition zone. So we all know that in the esophagus, the upper one third of the esophagus is skeletal muscle, okay, which has direct intervention from the vagus. And the lower two thirds of the esophagus is smooth muscle. This has an independent control. It has an autonomous control. So basically, when the peristalsis is going from top to the bottom, there is a transition zone where you see that the pressures are going down. So basically, it is going from one segment of the esophagus, which is skeletal, to the second segment of esophagus, which is smooth muscle. So here you will see an area where the pressure drops. Okay, so that is the transition zone. So basically transition zone is in pure sense, it is telling us the transition from CNS control of peristalsis to enteric nervous system control of peristalsis. Okay, then comes an important metric called contractile deceleration point. So contractile deceleration point in simplistic terms is that point where the peristalsis slows down. Okay. So if you see the peristaltic wave here, this is the velocity. So it's going forward, forward, forward with time. And here it kind of, it plateaus down, it slows down and becomes more horizontal. So basically what is happening, the peristaltic wave is going and it is now reaching the area of the lower sphincter. Okay. And here the peristalsis slows down because the emptying of the esophagus has to slow down because it has to overcome the lower esophageal sphincter resistance. So this point is called as the contractile deceleration point. It is that point where the peristalsis slows down. This is very important because with this CDP, we evaluate something called as the distal latency. Okay, so what is distal latency? Distal latency is the time between the onset of swallow and where the peristalsis slows down. So in simplistic terms, what it tells us in what duration is the peristalsis progressing towards the lower sphincter. So understand that peristalsis is a very coordinated activity. It cannot be too fast. So you can have a peristaltic wave which is very fast going down like this. Okay. So if the peristaltic wave is very fast, that is a detriment because if you have a very fast peristaltic wave, that will not lead to propagation of the bolus. The ultimate aim of esophageal peristalsis is to make sure that the bolus that we eat propagates and goes beyond into the stomach. Okay. So for that, it requires a coordinated effort of the esophageal peristalsis. So if the peristalsis is too fast, what will happen? The distal latency will become smaller and that is a detriment. That will not lead to bolus transit and that will lead to dysphagia. Okay, so that is what is distal latency. So distal latency is basically the interval between the upper sphincter relaxation and the contractile deceleration point. Okay, so the normal distal latency should be more than 4.5 seconds. That means the esophageal peristalsis has to go down after 4.5 seconds of the initiation of the swallow. Okay. Then comes a very important metric called as the integrated relaxation pressure. So integrated relaxation pressure, what it is telling us, how efficiently the lower sphincter is relaxing. Okay. So you cannot use your baseline LES pressures as a measure of relaxation. Okay. Because relaxation also is an active effort of the LES when the bolus goes down. So there's a specialized metric to that is called as the integrated relaxation pressure. So what integrated relaxation pressure is, it is the average of 4 seconds of relaxation in the lower esophageal sphincter zone. It is the 4 seconds of relaxation within the 10 seconds of swallowing. So let me explain that in this graph. So the patient has initiated the swallow, right? So from here, you start counting 10 seconds. In this 10 seconds, which are the 4 seconds where the pressure in the lower sphincter is the least? Okay. So it could be a contiguous zone or it could be a discontiguous zone. Okay. So in those 4 seconds where the pressure is least, that is what is measured. Okay. The normal for IRP is less than 15 millimeters of mercury by convention. Remember that 15 millimeters of mercury has come up through a very small study. It was a study done in 75 symptomatic controls. So always remember that this value of 15 is more. It just gives you an idea that somewhere near here is the problem. Okay, it can be lesser, it can be higher. So every machine has their own different cutoff. Okay, but usually, roughly, it is 15. Okay. Then comes the metric called distal contractile integral, that is the DCI. Okay. So what DCI tells us, it tells us how vigorous is the contraction of the esophagus. So what it actually means is that the esophagus also has to contract with a certain vigor, with a certain pressure. Only when it generates a certain pressure, it will be able to propagate the bolus downwards. Okay, so the vigor is basically a composite of the amplitude of the contraction, the length of the esophagus that is contracting, and how long is the contraction going on. That is a contractile duration. So when a DCI is being calculated, what the machine usually does, so it's an automated software derived metric. You don't have to do it physically. The machine, it generates a box like this, which is involving the distal two-thirds of the esophagus, that is the smooth muscle part, and this box is deriving this metric. Basically, it's a composite of the amplitude, the length, and the time of contraction. Okay. So a DCI which is between 450 and 8000 is sufficient for the bolus propagation. If you have weaker DCIs, so if the DCI is less than 450 but it is more than 100, it is a weak peristalsis. It may or may not lead to bolus transit. If the DCI is less than 100, it's a failed peristalsis. This absolutely cannot propagate the bolus. There is also a problem if the DCI is very, very strong. So if the DCI is very strong, it's more than 8000. So you have an esophagus which is contracting very, very vigorously. So that's also a problem. That will also lead to dysphagia. Okay. So when we know all these metrics, okay, so the Chicago has given us a hierarchical structure, which I'm sure all of you know, is that you use all these parameters, you use the IRP, use the distal latency, use the DCI. So basically all you need to know for diagnosis is these three parameters, the distal latency, the DCI and the IRP, only three parameters. If you know these three parameters, you put it in a hierarchical structure and the Chicago classification gives you the motility disorder that is present. The landmarks are important because that is essential to see whether you're doing the right analysis or not. Okay. So we all know there are these three types of achalasia cardia. So what happens in achalasia cardia? You saw the normal graphs, right? So if you look at these graphs very carefully, here you see the patient has taken a swallow. You see there's a small break over here. We would have expected that the LES would eventually relax, but here you see the LES constantly has high pressures. In this graph also, in this graph also, and in this graph also. Okay, so the LES is not relaxing. In this graph, there is absolutely no peristalsis that you can see. In this graph, there is no peristalsis. So peristalsis is a coordinated wave, okay, which would go down like this. So here there's no peristaltic wave. There's just a pan-esophageal pressurization, right? And here there is a peristaltic, apparently there's a peristaltic wave, but basically it's a premature contraction. Here the distal latency is lesser. So this is achalasia cardia. Why? Because the LES is not relaxing, the IRP is high, the peristalsis virtually is absent. So when you talk of peristalsis, you're talking of a coordinated pressure wave. A coordinated pressure wave is absent in all these three graphs. Mind you, here also it's a contraction, it's not a peristaltic wave. A peristaltic wave is one which would have all the parameters to be normal. Okay, so this is achalasia cardia. Now, for the benefit of this audience, I would like to take things beyond achalasia cardia because achalasia cardia is something that we all tend to discuss and we all tend to focus in our routine practice. You know, achalasia cardia is so common. So everybody's focus is on achalasia cardia. But what we tend to neglect are these other motility disorders, you know, which tend to be present, more prevalent, in fact, but we don't know what is the significance or we don't know how to diagnose them right. Right. So I'd like to take you into more detail in disorders beyond achalasia cardia, right? So esophagogastric junction outflow obstruction, right? So what happens in esophagogastric junction outflow obstruction? Remember that EGJ outflow obstruction is a manometric diagnosis. It's not an endoscopic diagnosis. You know, endoscopy, if you find something which is there at the G junction, that's a mechanical cause of obstruction. But when you talk of EGJ outflow obstruction, it's a physiological presentation where the patient is coming with dysphagia, where the IRP is high, but you don't see any obvious reason why that is happening. Okay, so that is EGJ outflow obstruction. So what happens in EGJ outflow obstruction on the manometry? Your IRP is high. Here you see the LES is not relaxing, so obviously your IRPs will be high, but your peristalsis would be absolutely normal. A patient with EGJ outflow obstruction present with typically with dysphagia. Okay. So here, if you see this graph again, here you see that this appears to be again EGJ outflow obstruction, right? The IRP is high, the peristalsis appears normal, right? So here in this graph, if you see very carefully, you see that there are two high pressure zones. There is a high pressure zone over here. There's a high pressure zone over here. right? So this high pressure zone is because of the LES. This high pressure zone is because of the crural diaphragm. So this patient has a small hiatus hernia, and small hiatus hernia are known to cause EGJ outflow obstruction. Okay, it's one of the commonest reasons for presenting as EGJ outflow obstruction. So when we talk of EGG outflow obstruction, now we all know that now you are dealing with Chicago 4 classification. Previously it was Chicago 3. So the Chicago is a group of experts in this field of manometry who come together and create a consensus. Okay. So this what has been different in Chicago 4 is that Chicago 4 has focused a lot on EGG outflow obstruction. And the reason is when we used to do manometries previously, and most of us, fortunately or unfortunately, depend on the machine to give a diagnosis, use the automated software, and everybody started realizing that a lot of diagnosis which was done by the machine was reported as EGG outflow obstruction. So if you do manometries in 100 patients, 10% of all the patients, 10 out of 100 would be reported as EGG outflow obstruction. And many of them were spurious. They were not actually GG outflow obstruction. They were spurious because the finding that was coming was because of a catheter artifact, or there was a mechanical effect. There was something compressing over there like a hiatus hernia. So obviously these cases are not true EGG outflow obstruction. They don't require any treatment. You just need to diagnose them correctly. But you need to find out which are true EGG outflow obstruction. That's also very important because a small proportion of these EGG outflow obstruction actually evolve into achalasia, or they represent an achalasia variant where you need to treat them as achalasia cardia, right? So what you need to do is to first step that you need to do when you have an EGG outflow obstruction is to change the patient's position. Okay, you do primary position of doing a manometry is a supine position. You have to use secondary positions as recommended by the Chicago 4, especially for EGG outflow obstruction. So here you see a classical graph where in one position the patient has EGG outflow kind of a picture. When you change the patient's posture, this has vanished. So basically this, what was happening here was an extrinsic compression. Okay. So the Chicago 4 tells us that for conclusive EGG outflow obstruction diagnosis, it requires three parameters. The IRP should be elevated in primary as well as in secondary positions, and 20% of the swallow should show intrabolus pressurization. There should be a clinical relevant symptom like a dysphagia or a chest pain, and there should be at least one supportive investigation like a timed barium esophagogram or a endoflip or a barium tablet. Okay, this is very important. So, very important whenever you have diagnosed EGG outflow obstruction, do a good, maybe repeat your endoscopy and see on retroversion, are you missing out on something, right? So this is an example where this patient had come to us with achalasia kind of a pattern where you see that the IRP is elevated and there is an pan-esophageal pressurization. Endoscopy also did not reveal very obvious findings, especially for beginners. Okay, this seems to be normal, right? But there was a thickening. So this area is a subtle area of thickening which was picked up on the US. Here you see the muscle thickness to be significant, and we did a biopsy and turned out to be adenocarcinoma. So pseudoachalasia, this was a case of pseudoachalasia. So EGG outflow obstruction, pseudoachalasia, be very careful, right? Then comes your distal esophageal spasm. So a patient with DES, distal esophageal spasm, will typically present with intermittent dysphagia. It tends to be intermittent, comes and goes, and a typical esophageal kind of a chest pain. Manometry, you will see that the distal latency is less than 4.5. Rest everything is normal. Okay. But whenever you diagnose a case of DES, remember that pure distal esophageal spasm is extremely rare. Extremely rare. So it's usually a part of type 3 achalasia cardia. DES is often secondary to reflux disease. So try to treat reflux before you plan a major intervention. Directly don't jump in to do a thing like poem for DES, because poem is recommended for patients who have DES over a prolonged period of time. Okay, remember opioids can cause DES. I don't know how common is opioid abuse in that part of the country, but you have to ask for this. Remember that higher number of swallows, patients who have higher number of swallows who present with typical findings. So out of 10 swallows, 5 are showing decreased distal latency. Your confidence of diagnosing DES goes on increasing. If one order swallow is showing decreased distal latency, be very careful before labeling this patient as DES. Okay. One of the important, considerations when you're diagnosing this is to localize the contractile deceleration point. So you have certain cases where you have kind of a step ladder kind of a peristalsis. So there, where do you place the distal latency? Because your distal, where do you place the CDP? Because your distal latency actually depends on the CDP, right? So your CDP has to be on the 30 millimeter isobaric contour line and it has to be within 3 centimeters of the LES. So make sure that your distal latency is not going very high up. It has to be within 3 centimeters of the LES and within 30 millimeters of the isobaric contour. Okay, jackhammer's esophagus. So jackhammer typically is where you have very high DCIs, where DCI is more than 8,000. Other parameters are normal. These patients again present with intermittent dysphagia and chest pain. Hypercontractile esophagus. So jackhammer is a type of hypercontractile esophagus. So basically this the broad subset is called as hypercontractile esophagus. Jackhammer is just one variant of that. So I am telling you this is that you can have a situation where the increase in DCI might just be localizing to the very lower esophagus and to the lower esophageal sphincter also. So whenever we are seeing for hypercontractile esophagus, we are always trying to search for this kind of a graph, right? But always try to see for this kind of a graph also. You can have situations where the hypercontractility is localizing towards the area of LES. So that's also hypercontractile esophagus. Okay, so this was a very important study which was published by a Japanese group. So 89 patients who were diagnosed as jackhammer esophagus, eosinophilic esophagitis was reported in 21%. So significant proportion of patients. And 77% of the patients who were managed just conservatively showed complete resolution over a period of time. So again, what I mean to say, for conditions like DES or for jackhammers, try to go in for conservative management first before you go in for a therapeutic procedure. Try for at least 3 to 6 months. Because even if you see the success rates of POEM for varying disorders, the best success rates are for achalasia cardia. For spastic motility disorders in general, the success rates are lower and lower, right? So never jump in. Don't jump the gun for and don't jump the gun for endotherapy in spastic motility disorders, right? Then comes an important entity called ineffective esophageal motility. So ineffective esophageal motility is where the DCI is very low or there are peristaltic breaks. So, with time, as we are moving ahead in Chicago, the Chicago criteria is making it more and more stringent for diagnosing esophageal motility disorder, for ineffective esophageal motility. In Chicago 3, if you had ineffective swallows which were more than 50%, they were labeled as ineffective esophageal motility. Now, Chicago 4 tells us that ineffective swallows should be more than 70%, right? To label this patient as ineffective esophageal motility. So what is the consequence of ineffective esophageal motility? It might or it is usually a consequence of GRD. Okay. So ineffective esophageal motility can be seen in normal people also. Okay. And it can be seen or it's usually seen in patients with GRD. Okay, so how do you know which is important? So you can have a normal variant of ineffective. A lot of normal people who are asymptomatic, you do esophageal manometry, you see that there is ineffective motility. In patients with GERD, it's very common. Patients who present with dysphagia, there the problem is the ineffective esophageal motility is actually causing a problem with abnormal transits of the bolus. So we need to, further evaluate these patients. Maybe the future iterations will tell us how to evaluate these patients. So ineffective esophageal motility can be seen in 30% of all patients who undergo esophageal manometry. Okay. So in GRD, whether ineffective esophageal motility leads to GRD or whether GRD leads to ineffective motility is a big question. It's like a chicken or egg phenomenon. How GRD can lead to ineffective esophageal motility is because when you have acid reflux going on into the esophagus, the acid actually, desensitizes some mechanoreceptors and it actually impairs the motility. That is the hypothesis, right? So I'll not go into much details. Why this is important is that you will be referred patients who are planning to undergo an anti-reflux surgery. So patients who are about to undergo an anti-reflux surgery and you diagnose ineffective esophageal motility, previously it was considered that you should not do a 360-degree fundoplication in these patients. a partial fundoplication is okay. But now studies have very clearly told us that only ineffective esophageal motility does not predict post-fundoplication dysphagia. What you should do is that you should do a simple maneuver called multiple rapid swallows. So what you do in multiple rapid swallows, instead of the 5 ml swallow that you are giving to the patient, you would give 2 ml, 2 ml, 2 ml rapidly. So that is multiple rapid swallows like this. And then you would see for the distal, you would see for the DCI of the eventual peristalsis. So if the DCI of the eventual peristalsis is stronger than the DCI of the baseline peristalsis, that means there is augmentation of that peristalsis. That means there's a peristaltic reserve, and these patients can very well undergo a 360-degree fundoplication. Whereas in patients where you see that the augmentation does not occur after multiple rapid swallows, that means the augmentation is absent, and these patients should not undergo a 360-degree fundoplication. So only ineffective esophageal motility is not the metric you see for post MRS augmentation of the DCI, right? So I will not go into much details of this. Absent contractility again is a situation where the peristalsis is absolutely absent, but here the IRPs are not increased, unlike achalasia cardia. Okay, absent esophageal contractility can be very, very rarely seen. Unlike ineffective esophageal motility, if you have absent contractility, this is hardly ever normal, very, very small proportion. It can be seen in a few patients with GRD. It's pretty common in patients with connective tissue disorders, especially scleroderma. The most important thing when you have absent esophageal contractility is whether you are dealing with a patient with type 1 achalasia cardia, right? In type 1 achalasia cardia also you will have complete absence of peristalsis, and you will have a subset of patients with type 1 achalasia cardia who have a very low IRP also. So how do you differentiate? How do you differentiate whether this is type 1 achalasia cardia or absent contractility? Right? So 25% of type 1 achalasia cardia and absent contractility can be misdiagnosed using our conventional Chicago classifications. So here you do something called as a rapid drink challenge. So rapid drink challenge is when you ask the patient to rapidly drink around 200 ml of liquid, and there you would see what happens to the IRP. Okay. So if after a rapid drink challenge your IRP increases, this is a case of achalasia cardia. If the IRP does not increase even after pushing the esophagus, this is a case of absent esophageal contractility. A timed barium swallow in such cases might be useful. So there are very few situations now where we actually use a barium swallow. Virtually, our usage of barium swallow has become non-existent with good quality manometries that are available. So, ladies and gentlemen, esophageal motility disorders are heterogeneous. Non-achalasia disorders are more prevalent than classical achalasia. Understanding manometry evaluation and management principles are important for accurate diagnosis and treatment. It is time to also see beyond the spotlight. Thank you so much.
Sometimes it was a great talk, Dr. Sometimes you do get ineffective esophageal motility as well as EGG obstruction in GERD. Is that something you just highlight on that?
So as I discussed, sir, if you are getting an EGG outflow obstruction, the first thing that you need to do is to change the patient's posture and see if you're dealing with an artifact. It could be a catheter related artifact, it could be an extrinsic compression related artifact. The change in posture, if it reduces your IRP, that means this was a false case of EGG outflow obstruction. Then comes dealing with your ineffective esophageal motility. As I said, if it is ineffective esophageal motility and you're planning to do an endotherapy or a surgical therapy, you do your multiple rapid swallows and see if there is an augmentation or there's no augmentation.
Sometimes we used to get negative IRPs. So what may be the problem with the analysis part or procedure part?
So having a negative IRP is okay. It's normal. So the usual reason is that your the tip where you are measuring the IRP is lying within a hiatus. Okay,
Okay.
so having a negative IRP is not a problem. You can have negative IRPs. The problem only is when the IRPs are, higher. A lower IRP, a negative IRP is not a problem.
So in that case, the basal pressures are sometimes normal and IRP is negative.
The basal pressure means?
Basal sphincter pressures, lower esophageal sphincter
Yeah,
pressures.
yeah, that so basically what happens is during the phases of inspiration and expiration. So when there is inspiration, your LES pressures would definitely go down. With expiration, they'll come up. So when you're measuring the IRP, you're measuring a composite of both inspiration as well as expiration, right? So that can give you a composite IRP which is lesser than the basal pressure. So that's absolutely normal. There's no problem with that.
Any more questions? Thank you, Dr. Srihari, for a very, very lucid presentation. Thank
Thank
you
you.
on behalf of our group.
Thank you. My pleasure to be here, sir. Thank you so much.
After Dr. Srihari's exhaustive talk, I think mine will be pale in comparison. Nevertheless, I've titled it aptly, and after this, if there are any questions, I'll be happy to answer. Are my slides visible? They're very small. More than slides, we're actually looking at, what all we're looking for in esophageal manometry, anorectal manometry in simple. If there's anything at the end of the session or in between, you're free to interrupt me. So I titled it as "Take Care of Your Rear End" because I think there is a lot of hesitation with people coming in with constipation, and they don't come very forthcomingly with symptoms. So when they do come to you with refractory constipation, let us all remember that anorectal manometry is not the first diagnostic test in a patient with constipation. So I wouldn't want to go into Rome and other things, but we do know that patients who have been evaluated appropriately and been on specific and correct therapy, appropriate therapy for their symptoms, and yet continue to have symptoms in the absence of red flag signs. That is very important. You've ruled out any organic causes or secondary causes of constipation. So for the treatment or further evaluation of functional constipation or fecal incontinence, this is a valuable clinical tool which can be easily interpreted once we take the time to understand the different components of anorectal manometry. So what is anorectal manometry? It is very akin to the same catheter that we use for the esophageal manometry. It is a 16-channel catheter. Of course, I talk about water perfusion catheter because that is what we use, and I do not have an experience with solid-state catheters. We find them quite easy to use and user-friendly, easy to interpret as well. So what all is the component of an anorectal catheter? So we know there are 16 channels and the catheter had 16 ports with side holes. The addition in an anorectal manometry catheter is we add a balloon at the tip of the catheter. This is for the assessment of the balloon expulsion as well as for the elicitation of the RAIR and the assessment of rectal sensation. And we generally use the end of a latex glove as a balloon, and we use smaller ones in the case of pediatric anorectal manometry. What all are we essentially looking for? Before we look at parameters, we don't ask for any specific bowel preparation. All we ask is for a suppository to be inserted about 2 hours prior procedure. In children, most of them come as referrals to our institution. They are generally pre-medicated either with an enema or suppository. In the presence of all this also, however, if there is any fecal loading or acute sphincter spasm, we do not proceed with the procedure at all. Once all these parameters are fulfilled, the rectum is not loaded and the patient is comfortable, we do the manometry in the left lateral position, though not physiological. We have not progressed to maybe further or newer postures for anorectal manometry. Maybe we should look at that as a future research methodology. In any case, these are the 5 components of a simple anorectal manometry. One is the basal pressure, second is the squeeze pressure, third is the attempt at straining and the sphincter changes accordingly. Fourth is the elicitation of the rectoanal inhibitory reflex. This is quite important in pediatric anorectal manometry, where referrals are for evaluation of Hirschsprung's disease or infantile neonatal constipation. And the last is the ability or inability to expel a balloon. So What all are the components of the basal pressure? It basically assesses the integrity of the internal sphincter as a majority, to a small extent the external sphincter. Normal values are anywhere between 40 and 80. When values exceed 100, even in a relaxed patient, this is one of the diagnostic criteria for anismus, or one of the constituents of a dyssynergictification if other values also corroborate with a high resting basal pressure. What is the squeeze pressure? The squeeze pressure is an indication of the external anal sphincter integrity, as well as the sling muscles which help to maintain or augment the external sphincter, including the tuborectalis. Now, for the continence of solid stools, a squeeze pressure of about 70 to 80 mm of mercury is sufficient as the low limit of normal. However, if patients have loose stools, even with these pressures, this does not qualify as adequate, and patients will present with urge or unawareness of incontinence of stool. Now, straining, this indicates three things. One is the ability of the intra-abdominal muscles to strain to start a defecative process, the ability of the rectal muscles to transmit this, and the relaxation appropriately of the anal sphincter in response to pressures from the intra-abdominal muscles. So when there is an adequate sphincter relaxation, what happens during physiological defecation? We know that to maintain continence, there is an angulation of the rectoanal angle. Otherwise, if it is always open and straight, there might be inadvertent leakage of stool. So this angulation helps to maintain a continence, or a presence of stool in the rectum without leakage. So when a person feels the desire to defecate, what happens? He or she applies a pressure from the abdominal muscles, which is then transmitted to the rectum, which results in the straightening of the rectoanal angle and a relaxation of the anal sphincter. This helps the stool bolus to be transmitted from the rectum to the anal canal and to the exterior. This is normal physiological defecation, and we know that it is maintained by a complex neural mechanism as well, involving the sacral arc. So straining can be excessive, straining can be ineffective, or it can be normal, and this associated problems are a reflection of the same. We'll speak about it more in detail as I show you the components of the ARM. And the RAIR, we know that this is a local spinal reflex, and this is not affected by sedative mechanisms. The reason I mention this is, in case there is an infant or a child which needs an RAIR, it can be done even under sedation. Medications like glycopyrrolate, however, might affect the RAIR. Otherwise, this can be elicited even in a sedated patient. So the absence of an RAIR could imply two things. What is a normal RAIR? RAIR means the rectoanal inhibitory reflux. So this is elicited by insufflating the balloon which is attached to the tip of the catheter and looking for an initial transient increase in the anal sphincter, followed by an immediate sustained relaxation of the same. Why I'm using these adjectives is, if the anal sphincter relaxes after a prolonged period of contraction, this is not a true or a physiological RAIR, and it has to be looked for again to be sure whether it is present. So when we say an RAIR is absent, it means that there is a paradoxical contraction of the anal sphincter in response to balloon insufflation, which persists, or there is no relaxation of more than 30% from the basal anal sphincter pressures. In children, this has to be elicited very cautiously, because children are awake. Sedation in all children is not practical. One has to be sure that the child is adequately relaxed before eliciting the RAIR, and be very careful before saying that it is absent. because we all know that the incidence of Hirschsprungs is low. So before saying RAIR is absent, one should look out for any other irritant factors that is not allowing us to elicit the same. Here, there is a component called areflexia, which means that there is a failure of absence of elicitation of the RAIR. But if you were to look at a full thickness rectal biopsy, there is the presence of ganglion cells. So this is not Hirschsprungs, but RAIR is absent. This can be seen in some patients with severe functional constipation. That is one of the theories. One of the theories is that there is some other organic problem in the anal canal which is responsible for the same. So this is about the RAIR. The last part is the balloon expulsion. What do we do in the balloon expulsion? In our institution, see, air or water, both can be insufflated in the balloon to elicit the balloon expulsion test. We use air as a principle. So we generally insufflate about 50 ml of air in the balloon and ask the patient to bear down as if he or she would desire to pass stool. So what we expect in a normal balloon expulsion is the ability to expel the balloon with appropriate contraction of the abdominal and rectal muscles and a relaxation of the anal sphincter. Within a period of 60 seconds, we expect 60 to 90 seconds, we expect the patient to expel a balloon. This is a normal balloon expulsion. Now, this is all the components of a normal manometry. Once a patient is unable to expel a balloon, we will have to look at causes for the same, which we shall discuss. So this is just diagrams to show you. Here you're seeing that the patient is utilizing only the anal sphincter to augment the sphincter pressures in a squeeze maneuver. If you were to see pink lines at the bottom of the anal sphincter, then it would mean he or she is using the gluteal or the thigh muscles to augment the squeeze, and that should not be considered the true squeeze. What you're looking above here, the green and yellow, is the area of the rectum, and the band that you see is the anal sphincter. Now, if you were to look at the second diagram, you will see this green and yellow has now become pink, which means there's an augmentation of rectal muscle pressure. And you can see there is a beautiful relaxation of the anal sphincter in response to the same. So this implies a normal strain pattern, and we would expect such a patient to have a normal or a successful balloon expulsion. If you were to look at the third diagram, you can see that a balloon has been insufflated here. There is an initial transient increase in the anal sphincter pressures, followed by an immediate relaxation of the same. So this is a normal. So this is just in summary of what I told you just before, but this is what essentially comprises the ARM. Patient to be rested to evaluate the resting or the basal tone. Ask the patient to squeeze voluntarily to evaluate the squeeze pressures. Again, a cough maneuver is also a very useful maneuver. We do this after the squeeze maneuver to look for the reserve function of the anal sphincter in response to intra-abdominal pressure rise in the form of coughing. Then we do what is called as a simulated defecation or a push maneuver to assess the rectal propulsive pressure and anal response. Here, I would like to just inform the audience that when a patient is asked to simulate defecation, in about 30% of patients, you will see an adequate rectal push, but you might look at the paradoxical contraction of the anal sphincter. Please do not make a diagnosis of dyssynergic defecation. Wait for the balloon expulsion, which is the gold standard to diagnose dyssynergic defecation. 30% of patients can have a paradoxical response in attempt of simulated defecation. Very often this is seen in slightly anxious patients or patients who are scared of incontinence. And of course, we do the RAIR and the rectal sensation. What is rectal sensation? This is the ability of a patient to feel the distension of the rectal balloon. Normal rectal sensation is perceived anywhere between 30 to 50 cc of rectal balloon insufflation. In patients with painful anal conditions like a fissure or sometimes with SRUS, patients may have rectal hypersensitivity where they're exquisitely sensitive even to 30 ml of air insufflation. We keep progressively distending the rectal balloon till the patient is able to perceive first rectal sensation, till the patient feels discomfort or significant discomfort when the balloon pressures increase. So when patients fail to feel rectal sensation between say 100 to 150 cc of air insufflation also, this is one of the diagnostic criteria for a rectal hyposensitivity or a megarectum, and this is often seen in patients with functional constipation with fecal loading. It is also seen in children very often with functional constipation. So after you evaluate the rectal sensation, the last part is the balloon expulsion, where you ask the patient to bear down. Here it is very important for us to guide and explain to the patient that it is okay if there is a little bit of stool leakage. A lot of patients find the balloon expulsion part of the anorectal manometry very uncomfortable because they are very, very worried about soiling. So unless your patient is comfortable, sometimes you might not elicit the correct response to a balloon expulsion attempt. So all this was the original or the standard components of the anorectal manometry. Then we now have some new wine in an old bottle. So now we don't have what is called just routine anorectal manometry. Like Chicago is going up and up, we now have the London classification, which is a new nomenclature for anorectal manometry disorders. Here, the main difference is we are looking at components of the anorectal manometry and classifying disorders as major or minor. Major, which is clinically significant, minor, which can be seen in significant number of healthy population as well. So we know that rare is a very, very important component of the rectal manometry, and absence of a rare is significant. Now, disorders of anal tone and contractility. If you see the London classification also, all the different components are there even in this. Just that the nomenclature is slightly different and they have been split up into the different parts. So if you look at anal tone and contractility, hypotension or hypertension, which essentially means the basal resting tone of the anal sphincter, and hypocontractility, which is possibly reworded as a ineffective anal squeeze pressure. Now, if you look at a combined sphincter dysfunction, which is called now anal hypotension, which means there is ineffective resting as well as squeeze pressure. Now, again, we know in our older classification, dyssynergic defecation, some authors say there are 3 types, some authors say there are 4 types. What does dyssynergy essentially mean? In the response to an adequate rectal propulsive force, there is either an abnormal increase in anal sphincter pressures, failure of relaxation of anal sphincter. One type is also associated with ineffective rectal propulsive force itself. So these were the types of dyssynergic defecation. Type 1 is paradoxical contraction, type 2 is when there's a failure of relaxation with adequate rectal propulsion, and type 3 is inadequate rectal push, which helps to propagate the stool past the anal canal, and the anal canal pressures do not fall adequately. So here it is reworded as abnormal expulsion either with dyssynergy, which is type 1, abnormal expulsion with poor propulsion, which is possibly type 3. And if you look at this, both poor propulsion and dyssynergia, which could mean failure of relaxation or paradoxical relaxation, paradoxical contraction of the sphincter. So the wordings are different, but essentially the concept or the components I feel are the same. And of course, rectal hyposensitivity and hypersensitivity, which are already discussed. So this is important for us. What is major? What should we give importance to? And what are seen in possibly healthy individuals as well? These are the components of the major findings in ARM as per the London classification. One is the absence of an RAIR, where you have a hypotensive anal sphincter, where there is a hypocontractility with a normotension, or there is an ineffective or let us say combined sphincter dysfunction. and a hyposensitivity and or hypersensitivity as per the case. This has to be very carefully elicited. These are the minor findings. Like I said, elevated resting basal pressures one has to be taken with clinical context. Abnormal expulsion with propulsion and abnormal expulsion with dyssynergia. If there are any questions at this point, I'll be happy to take them, or we can just move to case capsules as well.
We'll move, ma'am. Okay. There's one.
Madam, one question.
Yes, please.
Patient is not doing balloon if the patient is doing balloon expulsion, but he's is not able to perform, that is rectoanal incoordination is present. So in that case, normal expulsion with rectoanal incoordination is present.
That is what, ma'am. The thing is, this is what I'm saying. When you look at a simulated defecation, you ask a patient to simulate defecation in the absence of an inflated balloon. Yes. About 30% of patients will show an abnormal response. Yeah. That is not characteristic of dyssynergy. If a patient is successfully expelling a balloon with a controlled traction, then that is the gold standard for us to decide presence or absence of dyssynergy. So if he or she expels, we yet consider it as a normal manometry, normal balloon expulsion.
Okay, so we can give the report as
definitely, normal, definitely, yes.
Normal propulsion.
Yes, yes.
Normal
yes.
So
normal.
He's
because that, like I said, it is very. If you look at only simulated defecation, if you don't move ahead to the next parts, 30 to 35% will be labeled as dyssynergy if you're only looking at their attempt to defecate, because by the time they come to the fifth step, they're a little more comfortable with the procedure also. So you will find a true dyssynergy at balloon expulsion and not at simulated defecation. So you can give it as a normal balloon expulsion. So it as such rules out dyssynergy.
So rectoanal coordination is present.
Yes, yes. That is assessed by the balloon expulsion.
Okay. Well, okay, thank you.
Any other questions?
No, ma'am. We'll move forward.
Fine. So this is a classical case. This is a patient who presented to us with excessive straining at stools, sense of incomplete evacuation, history of digital evacuation of stool, on and off bleed PR, had a hemorrhoidectomy at some point. This time the sigmoidoscopy was consistent with a solitary rectal ulcer. And if you look at the manometric parameters, rectal anal sphincters, resting anal sphincters were about 101, high normal, high. Squeeze was 188. If you see the rectum sensation was preserved, RIR was also well elicited. Only thing is, when the patient has adequately strained to pass stools, you can see that there is a significant paradoxical contraction of the anal sphincter. So this will result in a failed balloon expulsion. Such patients do well with biofeedback therapy. Now this is the other component of anorectal manometry, that is the inadequate or hypocontractility of the anal sphincter. This is a 44-year-old female who has increased stool frequency with urgency. She's incontinent of loose stools, can manage with solid stools. There are no urinary symptoms. She's had history of a prolonged vaginal delivery with assistance with instrumentation. And the rectal examination also indicates there is a suboptimal squeeze pressure. So if you look at this, basal pressures are about 46, squeeze pressures about 69. All the others are normal, including a normal balloon expulsion. So this squeeze pressure may help her to maintain continence of solid stools, but once stools are semi-solid or liquid, there is bound to be incontinence. So this is a diagnosis of a anal sphincter hypocontractility. These are the only things I have at this point of time. If there are any other doubts with respect to ARM, I'm happy to answer. Before anything else?
Any particular findings in neurogenic patients who have constipation. We have a lot of referrals coming.
Yes, sir. Yes,
from
sir.
patients who have got a stroke or paraparesis. They have constipation. Sometimes they have a rectal bleed.
Sir, in such patients, what we find is because of the disruption of the neurological arc, the RAIR would have been preserved, but they will have complete hyposensitivity. So they will absolutely not, and that will be prior also assessed by a diminished perianal skin sensation perception, or even your digital rectal examination itself. A lot of them will have rectal loading. So what we find in such patients is they are able to assess, give you some kind of rectal propulsive force, but what is characteristically absent is the rectal sensation, which is seen in patients with stroke or paraparesis, head injuries, traumatic falls, etc. Yes, sir.
Second is sometimes from the surgery, say traumatic, say when they have done a diversion colostomy, then before they do it, they ask continence, they ask for a rectal manometry. So what are the things we need to look into that before we could say that they can revise the colostomy?
Sir, essentially when they're asking us for revision, this could be due to various reasons, like you say, one is traumatic, one could be just essentially low rectal tumors where they have done a diversion. So they want to know mainly the continence of the anal sphincter. So what we look for is for an adequate squeeze. So such patients, first thing you have to notice is they should not have a tender rectal examination. Sometimes there is a long gap between the surgery and the anorectal manometry. There will be some amount of diversion proctitis. So if you see, there will be very tender even to simple balloon expulsion if there is significant inflammation. So what we generally ask the surgeon is, either do a sigmoid, or we should at least have a look at the ronal rectum before we actually proceed to the manometry. Otherwise, patient cannot cooperate. We look for both sensation and an adequate squeeze pressure before saying patient can go for reversal of stoma. Both are essential for reversal of stoma.
Basal pressure should be within the normal range, or
definitely, ma'am. We should at least a basal pressure of 35 to 40 mm is required for incontinence or soil prevention of soilage. Squeeze pressures anywhere above 80 mm of mercury is enough to prevent continence. Yes.
And one more thing, this RAD for RAD, contraction followed by immediate relaxation.
Yes.
Is there any numerical or percentage, in London classification, is there any particular numerical value?
There has to be at least 30% of relaxation. There has to be 30% of relaxation. And it has to be immediate. Anything more than 10 seconds should not be considered as a normal rare.
What we find is, in the recording, we are able to find the relaxation, but in the automated analysis, it is saying it is absent. But
one more thing, ma'am. That is one more thing I wanted to tell you. Thanks for bringing that up.
Sometimes we are not able to find in the automated analysis, it is coming, it is absent, but we are able to see that relaxation.
The main thing, this is what I wanted to tell you. Why I mentioned that London is a old wine and a new bottle is everything is automated. Similarly, even with Chicago, if you see, the moment you say analyze, everything is analyzed. That is where the presence of the physician or an adept comes in.
Switch off the automated and manually.
You have to manually. Right? And for example, just a corollary to the esophageal manometry, that way it helps to understand. There will be contractions which are labeled as fragmented. So if you let the result run, it will say ineffective esophageal motility. But you are seeing that patient has contractions with the DCI of more than 750 and symptoms are not corroborating. So you will have to take the findings in view with the clinical situation. So when you are seeing the RAIR present, you can actually change. You can manually change the reading and say present. So you need not take the software report as final. You will have to change it because you are there when the procedure is being done and you have seen the relaxation.
Thank you. So most of the time it is coming in.
Thank you very much, madam, for your time.
Thank you,
Sometime you can visit us and then probably
absolutely, sir.
Spend some time with us with acting the cases and because we do quite a bit of analytical manometry. Probably when you come, we can refine our techniques, number one, and also probably Also the biofeedback, probably we can fine tune it.
I did not bring in biofeedback here
Ah.
because I thought that would be an extension of the basic talk, but we do perform biofeedback. We don't have much experience for biofeedback in fecal incontinence, but we definitely do have enough data for dysenergification.
Yeah, we also do a regular biofeedback research. And
And
the CME is basically today we organized because we just started our Antroduodenal Manometry and video manometry today.
okay, sir. Congratulations on the same, sir.
Thank you so much. Thank you so much for your time, man.
Thank you.
Thank you.
Welcome, sir.
Yeah, hi. Hi, good morning from a cold Delhi. And first of all, I'm sorry that I could not be there physically. I was supposed to come, but there was some pressing family issues which I could not escape off. So I'm sorry about that.
One staff nurse is there.
So I will be covering two particular topics here. One would be, of course, the antroduodenal manometry, which you have just started. So congratulations on that. I think it's really uh, a big thing for a motility center to start that, because it takes time, but it gives you really a lot of information and gives you an edge for good patient care. So congrats on that.
Yeah.
Secondly, I will be talking about pH impedance studies. So I will start with the pH impedance studies once, and then I will go on to the antroduodenal one. So I'll just share my slides. Yeah, I hope my slides are visible.
Visible, sir.
So, first and the foremost, you must have covered esophagus manometry, you covered the anorectal manometry prior to this. So, 24 pH reflex impedance monitoring is something which I believe is not still appropriately done, because most of the time, in fact, much more than even manometry, we are dependent on the automated reporting done by the machine to us. And let me tell you, like exactly like manometry, the automated reports provided by the 24 pH equipment, irrespective of whatever equipment you are using, is not very accurate. And this is one place where the clinical context becomes extremely important for what you are doing the study. Just for a brief example, you may be doing it to diagnose GERD in cases when it's not sure. You may be doing it for adequacy of medical treatment. You may be doing it for planning of surgical treatment. You may be doing it for planning of an endoscopic treatment. And you may be doing it in terms of lung. So there are a lot of clinical situations where you would be doing this. And that is why the interpretation or a manual interpretation becomes extremely important when you are evaluating a pH impedance study. 90% of the reports that come to me from across the world, I had reports from Canada, I've had reports from US, I've had reports from Dubai, and I can tell you most of them are not manually interpreted, and at least not interpreted in the clinical context of what the patient is supposed to be doing. So, and why do we need to talk about all this? So, things have changed over the last few years. We were talking about acid the whole time, for years and years, and even the line as late as 2018, we were talking about acid exposure times. And we said that acid is the king, and whole of our gastroenterology, starting from PPIs and PCABs now, are centered around controlling the acid levels. But today it is not just acid, it is an integrated physiological approach. And when I say that, I mean you have to look at the acid, you have to look at the non-acid reflux, you have to look at what that acid or non-acid is actually doing to the esophagus, how is that acid changing the motility, and what are the changes in the histopathology which are indirectly reflected on MNBI or PSPW affecting motility. And that's how you will end up deciding how you will manage your GERD patient well. So GERD is not just looking at ulcers or acid, it is looking at how those ulcers and acid changing the motility and causing symptoms. So 24 pH impedance becomes imperative whenever thinking of any significant advanced planning for GERD over and above simple PPIs. So structural changes you will see on endoscopy. And when I say structural, LA grade B and above is something which is mandatory to diagnose GERD. Anything less than that is not GERD. But caveat, most of the patients who will come to you before endoscopy or even prior when you do endoscopy, they would be on PPIs. So even if they had LA grade B at some point of time, by the time you put your scope in, there will be LA grade A. So you really cannot diagnose GERD truly by only endoscopy. Next changes is the functional changes. What motility is happening because of GERD? And finally, as I said, histological. When you combine all of them, that's where you will make a proper diagnosis. Now, coming to the talk, why we want to talk of impedance and why we say that impedance is the gold standard here. So right now, just few slides, I'll cover what is basically impedance. So impedance is just the flow of current in between two conductors or two sensors. And in terms of the catheter that you will be using, in terms of two metallic rings that are there on the catheter. But in between that conductance, there has to be a resistance to the flow of the current. How much current can actually flow? And that's where we want to understand the basic concept. Current cannot flow in the air. Otherwise, we all will be getting, shocks here and there. So when it's not flowing in the air, that means that the air is resisting it. So the air has many, like very high impedance. So it is resisting the flow of the ions. Okay, so air has high value of impedance. Next comes water. Water has some ions. Some ions are flowing here and there. So some current will flow. That's why we say when it's a wet floor, don't touch, or you have wet hand, don't touch a electricity point. So some impedance is there. It is medium in water. But when you talk of salt water, the impedance has much low. So a lot of current flow. There is practically no resistance to the movement. So a lot of ions will keep on moving. So the salt water has much low impedance. So air, high impedance, plain water, medium impedance, salt water, low impedance. Remember these very basic concepts. When you talk of the GI tissues or GI food and everything that we eat, look at these values. Your gastric content is like salt water. It has very low impedance. Your food like custard, desserts, curds have around moderate, around 400 impedance. Drinking water, 1100. Esophagus wall is around 2000. So like medium to high. But air, as we said, is very high. Now, what happens when we are swallowing? How does a bolus move? Look at this diagram. Let me just put up my pointer here. Yeah. So you have these metallic rings, those are the impedance rings, and you have a pressure sensor here. The yellow thing is the catheter once we put inside. When we are eating something, what happens? There is an air in front of the bolus, this sky blue rounded structure. Behind that is the water or a food that we have eaten. And behind that is the esophagus wall, the green one, which is contracting to push the water or the food down. Okay, that's how a normal swallow works. Now, what happens if we want to calculate the impedance here? At the baseline signal, when nothing is in contact with the conductor, you have a baseline impedance signal like this. Okay, there is no pressure here because nothing is touching the sensor and the impedance is baseline. Next, the air comes in contact. And what did I say? Air has a very high impedance. So impedance goes up. Okay, pressure is still the same. Nothing has changed. Next, water comes up. So water has an impedance which is lower than the air. So impedance falls like this. And after that, the mucosa touches, the esophagus wall touches, and it has also a moderate impedance. It will again go up and then it will come back to the baseline. So this is how a food swallow or a water swallow will move down the esophagus and cause changes in the impedance. Remember this diagram well, because I'm just running it through a few times because this is a very dynamic phenomena. And once you have to start interpreting the recordings, you have to remember this diagram. A slight increase with the air then a dip with the water or the bolus, and then coming back to baseline with the high one. And this is where the pressure also increases. That's where the esophageal wall touches the sensor. So this is how an impedance signal works. I hope this concept is clear. I'll be going slow here. Eventually, I'll be going a bit faster when we start reading the studies. So now what do we do? What do we have? We have these catheters available to us. They can be single use or multi-use. They are antimony based. They have multiple, rings, 7 to 8 rings, and 1 or 2 pH channels. The standard now is to have a dual pH 8-ringed impedance study. So this is how it looks like. Once you are inserting it, you insert the distalmost catheter, the sensor in the gastric pH. That means where you are measuring the gastric pH, and then the other one is 5 centimeters above the LES. So you are measuring the esophagus pH with the esophageal pH sensor, and the rest are the rings which measures the reflux in the esophagus wall, and it comes till almost 17 or sometimes even to 22 centimeters level. Now we have seen that recording, that animation. Now look here, in your graphs, you will have something either like this or something like this. Okay. You can see here impedance is coming down, again coming to baseline, and like this. If all the impedance channels show something like this and it is moving downwards, that is an antigrade movement. That's a swallow movement. So swallow starts here, goes here, and down towards your stomach. Everywhere it is going down, it is causing that dip in the impedance, then coming back. That's a swallow, normal water swallow or a food swallow. A reflux will be opposite of that. Similarly, if a acid in your stomach or non-acidic reflux or a food is coming back from stomach, it is going retrograde, but it's causing the same thing. A dip in the impedance and then coming back, a dip and coming back. This retrograde flow is the bolus or the reflux. So antigrade is swallow, retrograde is a reflux. So how do you now say acid or non-acid refluxes? You have already put a catheter which has a pH sensor also. If pH 1, that means the esophagus pH is showing the dip of the line below the pH of 4, that tells, as well as a retrograde flow, that tells you this is an acidic reflux. Whereas if the pH line is just touching pH 4 and retrograde flow, it is again a weakly acidic reflux. And if pH is above 4, retrograde flow, that's an alkaline reflux. So this is how you will identify on the recordings. Okay. So when will you do? As I said, once we have covered the baseline, the basics, when will you do the pH impedance study? Remember all these clinical situations. You have to diagnose GERD, you have to look at the non-responsiveness of PPIs. Why are PPIs not working? Before you label somebody as refractory GERD, and refractory GERD is altogether a different talk. I'll probably cover it sometime, but this is what you have to do. Evaluation of atypical GERD symptoms, chronic cough, sore throat, asthma-like episodes, LPR, ENT referrals of LPR. Pre and post fundoplication surgery not working or surgery not being done properly. Assessment of response to treatment to patients on PPIs, unexplained cough, rumination, gastric belching, supragastric belching, patients telling me nocturnal symptoms, in the evening I have a problem, so nocturnal breakthroughs, pre-lung transplants, post-lung transplants, very important. Lung transplant, reflux is a major contributor for them to develop chronic rejection. So in all these clinical situations, you do this. So remember, when you're analyzing the report, if you are not putting the clinical context, it's just a waste of money. How do you insert? As I said, there are two sensors. The number 2 goes to the stomach, number 1 comes to the esophagus. You can use a fluoroscopy, or you can actually even look at the pH. And if patient is off PPIs, you can see that pH 2 will be less than 4, and pH 1 should be pH above 4. And that's how you know you have localized it well. What are the standard definitions that you now use to interpret the reports. AET is the acid exposure time. It's the total time that the esophagus is exposed to a pH of less than 4. Bolus exposure time, duration of all the refluxes which are defined by impedance divided by the duration. Symptom index, how many symptoms truly had a reflux. Symptom association probability, it's an algorithmic score which tells you whether the symptom is associated with a reflux episode or not. And abnormal SAP is more than 95% association. What are the normal values? The Loyan said that above 6 AET is abnormal, 4 to 6 is something which is borderline. In Asia, we consider 6 and above. Then there are total reflux episodes of anything above 80. You should consider it as abnormal. Borderline values you can leave aside, but rest you should see. How do you interpret it? Just first look at the pH, whether there is acidic reflux or non-acidic reflux. Look at the D-Mister score, look at SI and SAP scores. Once you have a positive SAP reflux for an D-Mister which is high or acidic reflux, that's a true GERD. Otherwise, you're talking about either esophagus hypersensitivity when there is a no true reflux, but symptoms are also there, versus no symptom probability and there is functional heartburn. So this kind of a graph is what it looks like. Why I showed you the basics is because you have to manually cross-check it. Look at these values. This, by one glance, I know this is a reflux because impedance is increasing and then decreasing, increasing, decreasing, and this is a retrograde flow. So this is the true reflux. At this point of time, the pH was much less, so this is a truly acidic reflux. Same goes here. And I can show to my patient this diagram on the right side. Okay, all this red area is what is being exposed to the acidic reflux when you are having the symptom, and it is reaching till the Z1. That means the proximal most sensor. So patient comes to know immediately that yes, this is a true acidic reflux causing LPR. Look at here, this pH line has dipped below 4 here on the yellow mark, and it's a dip in the impedance, and there's a retrograde flow. So this was a truly acidic reflux. At this point of time, the pH impedance is above the dotted line. So pH of above 4, a non-acid, retrograde flow. This is a non-acidic reflux. So you can manually trace, and it takes hardly a second. It's like reading an ECG. The more you read, the understand you get. Let's just see a case. 40-year-old female, BMI 27, hypothyroid, heartburn, regurg. So symptom and volume, both are things are happening. Heartburn does improve with PPI. PPI responsive, but volume regurgitation is persisting. That means that troublesome regurg and cough is there. Endoscopy is normal, Hill's grade 2. Symptoms persist despite lifestyle modification and weight reduction. And she is referred to you to do something more. So what we have done? We have done a pH study in her, and what we see that the acid exposure time in total was 2.8 only. That means this patient has a normal D-Mister score. There is nothing acidic about it. So it's not the acid. But as soon as you look at the total number of reflux episode, it was 165. So patient was having a non-acidic volume reflux. These patients will still do good with anti-reflux surgery or endoscopic interventions for a Hill's grade 2 like a GERD-X or an ARMA. Next case, similar 35, heartburn and chest pain. No volume rated symptoms. It's basically heartburn and chest pain. Partial relief to PPI and prokinetics. Endoscopy Hill's 3. There is a large longitudinal 3 centimeter hiatus. Cardiac normal. He was being planned for a fundoplication. It's a very straightforward case that we all see in our OPDs. But we did a pH study. AET is 4.3. So D-Mister is 12. Reflux episodes are only 55. This patient was functional heartburn. No SAP, no SI. He just required neuromodulate. He required a baclofen, probably a a tryptomer or something like that, and that's what would have worked well. So be very, very careful on where you are reading these patients. Manual scanning is of utmost importance. You can use the automated scanning, but please make sure that I'll show you some of the mistakes that might happen. So true reflux with a symptom. This is a true reflux, and patient has pressed the symptom. So this point, the SI is definitely there, positive. SAP score of above 95%. Look at this patient. This was again labeled as, reflux, induced because he was having recurrent belching, abdominal distension. He was told to have a hiatus, planning for surgery. X-ray was this, what you can see. We did an impedance studies. It was all, you can see all the high impedances here. You can see all the things that off the roof. This was air, not reflux. It was pathological aerophagia in a young male. So he was practically saved from a major surgical intervention. Look at the wrong automated reporting. Look at the DMISTER score here, 247. This is from my own center when one of my technicians says, sir, we have done, oh, this is a report. And I said, no, you haven't done it right. What was the wrong thing here? Can anyone guess? So let me tell you what the wrong thing was, that when you were analyzing, as I said, there are two pH sensors, pH1 and pH2. The pH2 is in the stomach and the pH1 is in the esophagus. So when they were calculating, they did not change the reference catheter to esophagus sensor. So pH2, that means the gastric sensor was used to calculate the DMISTER score. And gastric pH will be acidic. So your DMISTER came at 247. It is absolutely wrong. So this patient, we had to change the report and had to go back and see what went wrong. And then once you're done these things, it becomes a nightmare to, as a doctor, to go back and see where is the mistake. It was just a change in the reference sensor to an esophagus sensor as compared to gastric, which required a change of reporting. Now, sometimes when you don't tell your patient things well, for example, I had a patient when I said, okay, we have put the catheter, now please go and eat whatever you want to eat and do whatever you want to do. He went and had a party with a lot of beer and whiskey and everything, and all the recordings were gone. So we have to really tell them well. Another young female who kept on retching, and we actually had I'll show you what went wrong. 1 second. Yeah, this is a video. Now, this is, you can see a nice recording here. All things look very, very well. pH is in place. If you leave it at automated, what will happen? So as I go ahead, everything looks okay. Nicely done here. Patient had a lot of retching. You can see pH going up. He was trying to, the impedance going up. The patient vomited out and the whole recording was gone. This happened after a few hours of the study in the night. The catheter was half out, and you can see later on there is absolutely zero recording. Here. You cannot interpret this at all. So please eyeball the study once before you say everything is normal. This is food-associated aerophagia. Patient swallows and then they has. This is a belch reflex. Because you can see this is belching, the impedance is going up. Whenever there is a belching, there's always a reflux happening at the same time. So this, the first one is the one on the, let me point the options, laser point here. This is a belch at this point, and this is a reflux after the belch. Yeah. So belching associated reflux. Now, last few slides only. I know it's getting a bit long. So there are some novel indices now for pH impedance, something called as a PSPW and MNBI. MNBI is mean nocturnal baseline impedance. So at the baseline, that means in the night when the patient is sleeping, you will record the baseline impedance. So MNBI tells you that it's a marker for an esophagus mucosal integrity. That means what did the acid do to the esophagus? It actually correlates to your LA grade B or C esophagitis. If you find a low MNBI, you will have, your possibilities are that it's an erosive esophagitis than a non-erosive one. So it takes a 3-minute artifact-free window around midnight, and that is used to calculate. It's a formula for it. Why how does it actually correlate? In healthy mucosa, you have very tight intercellular junctions, so high resistance or high impedance. So in case your impedance is low, baseline impedance is low, that means those tight junctions have become loose because of constant acid exposure. And that tells you that patient is having a erosive reflux. So a low MNBI is suggestive of uh, erosive GERD. A high MNBI is normal or functional heartburn. So there are some newer metrics like PSPW. I'll not go into that because that has been now been removed. Only MNBI is there in Lion 2. So that's what we need to learn. But if you read it in the theory, there are many of them. So 24 pH is of utmost importance in various clinical contexts. It's essential to do before any study. Make sure you are doing it well so you can tell your surgeons well. Once you tell your surgeons well, they will listen to you. And it's much more detailed than just that AET or a D-Mister score coming in. A combination of metrics gives you the best results. Manual scanning is definitely important. So that's for the pH impedance. If there are any questions on that, I'm happy to take before we go on to the antroduodenal one.
So can you explain about that SAP and how do we differentiate between functional heartburn and reflux hypersensitivity?
So whenever you are putting the catheter, you are telling your patient to. So on the machine itself, there are two buttons, two or three buttons. The first one is whenever they have a symptom. So and you can define that symptoms while you are starting the study. Symptom one, symptom two. If your patient, like for example, if my patient had heartburn as well as belch as an episode or a problem, his clinical problem was heartburn and belching. So I will record those two symptoms in the equipment. Okay, symptom one is heartburn, symptom two is belch. And whenever I will tell him, whenever you have them, press these buttons. So whenever I'm analyzing, the machine will tell me symptom one was pressed so many times, symptom two was pressed so many times. When the symptom one was pressed at that point of time, was there any true reflux happening or not? So that is SI, symptom, indices or symptom association probability. So it will calculate the whole thing and tell me that if my patient pressed it, let's say 100 times, was it associated with the reflux 100 times or not? If it is above 95%, then yes, that symptom is truly caused by a reflux. If not, then it's a functional heartburn. And that is why I said the clinical context becomes important, why we are doing it. So if your patient had a symptom of heartburn and you have just defined the symptom as, let's say, epigastric pain, it may not match well. So your clinical history is very, very important for SAP scores.
And reflux hypersensitivity, if the SAP is less than 95 or?
So reflux hypersensitivity. So first is pH, the AET more than 6%, D-Mister which is high, and the SAP scores of above 95. That is truly a GERD. Reflux hypersensitivity becomes that your pH, your AET is normal, your D-Mister is normal, but the symptoms are still being caused by some volume reflux. That is reflux hypersensitivity. And the third is pH is normal, D-Mister is normal, SAP is normal, just random pressing of symptoms at random times. That is functional heartburn.
How does it help in rumination syndrome?
So,
I have a boy who is about 13 years.
So the best way to diagnose a rumination or a gastric or supragastric belching is the high-resolution impedance manometry. That is the gold standard. That's not available everywhere. So we use this 24-hour impedance catheters, and you press, you record the symptoms of belching or rumination on the software, on the equipment. You ask the patient to press, or whenever they feel, or you tell the parents to press that button whenever patient has a rumination. And when it is happening, when you show them the manual recording, at that time you are not looking at the pH, not looking at the impedance. What you were just showing them is, okay, when you press this, the impedance, this is what happened. Just prior to that, patients will have a swallow or an antegrade contraction happening down, a fall in impedance, and after that, they will have a retrograde flow back. So you can tell them that this episode happens because you first swallowed and then you created a rumination back. So that's a gold standard of telling them this is what it is. If they really want to, and this is we use when they really want a proof of what we are telling to them. Some of the patients might not agree, it is pathological or it is just like a functional thing. For them, you can do the test, record for 24 hours, and show them that this is what you are doing during those symptoms.
So you can do video manometry. Video manometry will see the bolus movement. Physical.
The video manometry also. So what we're trying to talk is the dynamicity of the bolus while we are doing manometry. On a normal manometry, we are just looking at the pressures, created by the bolus. We are not actually looking at the bolus movement. The only way to look at the bolus movement are two things. One is the video fluoromanometry, what we just talked of, that you put a fluoro and you actually do. It's like combining a barium or a gastrograph along with the manometry. The other method is an HRIM, that is the high resolution impedance manometry, which is a different catheter itself, which can tell you regarding the bolus flow. So both the methods will tell you the bolus dynamic flows. And that's what you require for rumination or a belching or a supragastric belching.
We talk to the next talk.
Okay, so I'll just go on to the next one. You sure you don't want a break? We can go on because it may get a bit sometimes taxing. Shall I go on? So now we'll barely go on to we go down into the stomach now. We had talked of esophagus impedance and we talked of esophagus manometries. Now we go on to antroduodenal, which is why we all are here. And you have just started a case. I think it's almost two and a half hours now into the case. So let's talk of the antroduodenal manometry. So the problem, what is the problem here? So gastric motility is one of the least understood domains. Okay, so we don't really understand it well. The testing is limited. Research henceforth is also limited. One of the first small bowel manometries was done way back in 1983, where they did jejunal manometry patterns in a healthy patient. And they said that, okay, there is something called as a phase 1, phase 2, or a phase 3 MMCs, migratory motor complexes, and they defined the manometrically what patterns do we actually see. So it was the phase identification of phase 3 activity that was made that as one of the gold standard to identify for a small bowel or a gastric enteral motility. Then if we actually go on, it went on from till 2020s. A lot of things came about, ambulatory catheters, neuropathy versus myopathy. So things improved, but it kind of became stagnant because we didn't have anything to really test it by. And that's when we thought of a high resolution antroduodenal manometry. Now coming on to the stomach, how do you test a stomach? You can test by doing a gastric emptying time, which is available at a lot of centers, but there's a lot of overlap. If your gastric emptying is anything around 20, between 10 and 20, you are not here, not there, it can be dyspepsia, it can be gastroparesis. You have wireless motility capsules, which are, I think the production is now being stocked from Medtronic. And finally, you have the ADM that's considered as the holy grail of gastric or small bowel motility. It is limited. It used to be cumbersome. And now, but I think with time, with the new catheter that we have now, it's becoming much easier. One of the first studies on ADM came from SGPGI. Dr. Ghoshal did the study. And, they did show that new diagnosis, new drugs, surgery, specialized tests could be identified in a lot of patients who were suspected to have pseudo-obstruction as well as gastroparesis. I'll refer this article for all to read. It's a well-written article. Publications till 2024 were only 29, which will change. So, but so what does it mean? It's a time-tested methodology, but underused. Why? Because it's cumbersome to use. Accurate placement of catheter and accurate testing is required, which is tiring for this particular study. But the indications are increasing every day. We are seeing patients of suspected gastroparesis or rumination or functional vomiting or small bowel pseudo obstruction now. We do not have any normative values for India, and ADM can significantly change the diagnosis in close to 1/3 of your patients. What are the indications? Where do we do the study? Most importantly, it is suspected small bowel pseudo obstruction or chronic idiopathic pseudo obstruction. It is SIPO. This is extremely common with our pediatric colleagues where they are referred for this particular study. In adults, for GI medicine, we use unexplained nausea or vomiting, abdominal pain, gastroparesis. So having that age-old thing of food residue being in the stomach to diagnose gastroparesis will still miss at least 30% of patients who have gastroparesis. It is used as a part of GI testing for diffuse GI motility before, for example, you have a patient who have been labeled as a colonic inertia and asked for a colectomy. You need to look at small bowel and stomach before you go for a surgery for them. So in all the indications, antroduodenal manometry is required. Small intestinal pseudo obstruction on ADM has patterns which are abnormal and never present in healthy individuals. And clinically suspected SIPO or a small intestinal pseudo obstruction and the manometry is normal is usually functional disease. So that is why your ADM can give you a yes or no answer very, very clearly, abnormal or normal. If it's normal, it is usually not SIPO. We always exclude mechanical obstruction by all the means which we all are aware of. Some of these patients can be nutritionally depleted, so make sure you decompress the bowel, electrolyte correction, fluid restriction is required. 8 hours fasting, stop all the drugs which may affect the GI motility like prokinetics. Check for hyperglycemia and electrolyte disturbances. It can acutely affect the gastric motility. So if patient is diabetic, please make sure it's like the PET scan. Make sure you're not putting them on a DNS or have a sugar of high more than 180 before you start doing these tests. So this was the original catheters which was available, but now things have changed. You require a fluoro also to go along with it. I'll skip this. Yeah. So what do you want to do? Catheter placement is done via the nose using a guide wire under fluoroscopic guidance. We need to avoid excess air, and you can turn the patients. Also, you can change the positions if required. Minimal recording of 6 hours, 4 hours of fasting, 2 hours of post-fed state, and you give them around 250 kilocalories of commercial feeding, like Ensure or whatever is locally available. So this is the setup for the catheter that you have now. That's a 12 sensors in place. You have one channel for the guide wire. Here we are placing an 025 long exchange wire. You have to lubricate it very, very well, otherwise it will not flow through. Use the silicone oils of NJ. And once you can see the wire goes in and it will come out through the opposite side. So these are very, this wire guidance makes it extremely easy to place the catheter. In the morning also, I'm sure it must not have taken more than 5-10 minutes to place the catheters. How about it in the morning? Was it easy to along with the wire or was it challenging?
It was easy. It was okay.
So earlier catheter was simply were very floppy and they had 3 weights in the distal end. And that, it took me at least 2 hours to place those catheters in the beginning when I started doing ADM. But with this wire, it has become probably easy now. This is how the recording will look like when you are doing it. This is what I also saw in the morning when you were doing it. You can see exact position of the catheter in place, and I saw the similar thing in the morning when you had placed in your patient. So I think congratulations on that, your first case of ADM. You can also do some drugs like erythromycin or octreotide subcutaneously. Octreotide is easily available. It can be used to initiate the intestinal contractions, and erythromycin will induce the enteral contractions, phase 3 contractions, in case it's not happening during your study. So what do we do on the fasting state? You can see 3 distinct phases of MMC. What you have to check for, whether they are there or not, presence of MMC. whether they are propagating, going down into the duodenum, and how fast or how slow, what's the duration, and what's the predominant frequency. That means 3 cycles per minute, and the minimum contraction value should be at least 30 to 40 mmHg in the antrum. In the duodenum, you will see a faster contractions, a frequency of 11 to 12 cycles per minute. Again, the contraction should be at least 20 millimeters of mercury. Contraction can appear both in antrum or duodenum. It can be antegrade or retrograde. Sometimes you can, if you remember your endoscopies, the antral contractions can move both downwards or backwards. They will last for less than 4 or 5 minutes, followed by a phase 1, which is a quiescent phase, and then subsequent and irregular phase 2. So remember, 3 cycles per minute, 40 mmHg in stomach, 11 or 12 cycles per minute, 20 mmHg in duodenum. These 2 values you have to remember for phase 3 MMCs. This is how it will look like on the wired or on the line diagrams, but we can show on the high resolution duodenal manometry also. You can see that the pyloric ring has the highest contraction power, and whereas the distal antrum and the duodenal goes down significantly. So highest contraction frequency is used as a marker for the location. 3 cycles in 12, I told you. And only a pressure fluctuation of more than 10 is to be considered as a contraction. This is from a representative book on the ADM. You can see a 3 CPM, you can see an antral contraction here going down into the duodenal. Let me just show you. This is an antral contraction here, and these are the duodenal contractions. And this is from our own catheter. You can see a nice contraction happening in the antrum, multiple of them, in fact. 1, 2, 3, 4, almost 7 or 8 here. This black areas is the pyloric ring, highest pressure. And these vertical straight lines is for the duodenal contraction. So this is from our catheter. No, this was a case of a functional gastric outlet contraction. So this is abnormally high antral contraction. So it's not normal. So only I'm showing you this because it's seen very beautifully here. So it's a hyper normal contractions in this particular study. So usually we don't see that many crowded contractions in the antrum. They usually 1 or 2 or 3, and then they will die down, like the one you can see in this particular book image. So, and we also have the added software. Dr. Hubbard was kind enough to make it for us. You can use this. Will be, I think, will be given to you along with the catheters. So here it's not like the esophagus catheter or the software. There is no Chicago here. There is no London here. So it's just giving you the frequencies. Very easy to use. Like for esophagus, you put in the upper antral and the lower antral contraction, and you put in the upper duodenum and the lower duodenal contraction. The blue lines are the peak antral lines, and this is the white line is the duodenum peak line. Just place it visually, eyeballing it, and then on the right side you will get the frequencies. What is the frequency of the patient, number of contractions in the given timeline, number of antral peaks, and predominant frequency. You may not need all of these values that are given here. What we only want to see is contraction in the antrum, peak frequency, and the duodenal peak frequency. There are a lot of other parameters available in literature which have been incorporated in this particular software. If you want to use, you can use pediatric ones. They want to know many more markers. But practically, this is more than, these 3 values are more than enough. And identification of phase 3 contraction is more than enough for your normal or abnormal studies. Some of the other examples, so you can see post-fed, as soon as you give some feeding, the MMCs, the contraction that you are seeing are lost. There it becomes an irregular chaotic pattern, like in this particular diagram or image. During the postprandial stage, you see irregular and chaotic contractions as the grinding work will start. What you want to identify, myopathy versus neuropathy. In myopathy, you will have normal contractions, but low in amplitude, much more weaker. because the muscle is there, it's weak. In neuropathy, nothing is, it will be all chaotic, disorganized pattern. In autonomic, you may have normal contractions to begin with, but as soon as you give your food, it becomes, there is no response, there's no change. Long-standing uncontrolled diabetics will show you this kind of an impaired fed response or autonomic neuropathic changes. Like in this patient suspected SIPO, there are some enteral contractions happening here, but you can see no propagation, nothing going down in the duodenum, right? So this was a case of a neuropathic pattern. This was a patient who was suspected to be gastroparesis. Endoscopy, he was labeled as hiatus hernia. He underwent fundoplication, still had a problem. Gastric emptying study was normal. He underwent EGG. He was called as a hypernormal EGG and suggestive of functional entropyloric duodenal dysfunction, as was planned for GPOM. They ever did a balloon dilatation, and with some relief, he was finally being planned for a GPOM. But we did a ADM, and there were no contractions, zero, nothing in the antrum. So when there is nothing in the antrum, you really cannot. So whatever you are seeing, these small things are few of the pyloric contractions happening, but there is nothing in the antrum. There is nothing in the duodenum showing you some contraction. You can see the small vertical lines here. So duodenum is showing you some contractions, but the antrum is showing nothing. So this patient actually had a gastric absence of ICC cells, so he actually required a pacemaker rather than a GPOM. The first case that I showed you, one with the hypernormal contractions, just where you're probably doing a GPOM would have done a better job. So this is a rare thing you might find sometimes. This is called as a burst pattern, and it's actually a suggestive of mechanical obstruction. Sometimes if we have not excluded mechanical contractions well, you will have these weird contractions coming in, but this we will normally exclude it prior to be doing an ADM. So what are the applications for gastroparesis? We can identify pathological processes which are not identified by gastric emptying time or anything else. So problem is, how do we choose therapeutics? Pacemaker, GPOM, medications, are all gastroparesis therapeutically same? That's what the question was for us in the next stage. We want to differentiate functional things like rumination also along with gastroparesis. So what we did was what I thought, and this is a proposed one as of now. It has not, we are thinking of writing up this as a review, is a proposed mechanistic classification. Disorders of pyloric function, disorders of duodenal function, and disorders of entropyloric coordination. I know not go into the very detail of this. I can share you slides. So what we're thinking of is pyloric hypermotility, like the first case, pyloric hypomotility, like A2, like the last case, or disordered pyloric relaxation or accommodation. Same in the duodenum, hypermotility and hypomotility. And same for the coordination, as a failing of the contractions from the antrum going towards the pylorus as well as downwards into the duodenum. That's the thought process behind of this kind of classification. This comes from actually this article in 1986, where Michael Camilleri, who's still active, did a pyloric manometry study for patients with recurrent nausea and vomiting. And he said of these three patterns, and that's what we are also thinking of using the high resolution ones. I will also refer you to this particular article, Comprehensive Characterization of Enteral and Pyloric Contraction. This is a good review article to read if you have time. And it uses the high resolution ADM catheters also. So this was our data. It was presented in IDDF. It was published in Gut as an abstract last year. You have this catheter now available to you, and I think it will change clinical treatment and clinical management in a lot of patients. Does it predict response to GPOM right now? No, it doesn't. It can just but the same, even endoflip is not a predictive factor. That is the newest technology available for pylorus. So practically, we are good at defining the physiology and pathophysiology, but therapeutic predictiveness is still something which is out there. So ADM will give you pathophysiology, mechanisms, easier way of doing a study is available now. That's the first hurdle we have crossed, that we can do the study now. It is easy, commercially available, easy to do, cheap to do. So probably as your center has started, many others will do. We will create our Indian data and then finally do studies where we can talk of predicting therapeutic interventions based on ADM. So thank you so much. I would request all of you to manage your data, keep your data well, and publish it. We all need our multicentric studies. Thank you. Thank you so much. Yeah, I'm sorry it may look much in detail, but just want to cover everything.
Please only see. Please only see the other one that.
Sir, I have one doubt, sir.
Yeah.
Sir, regarding the postprandial post-state analysis, sir, what to see in the post-fed state, sir? Can you explain it with the?
So normally what you would expect in a post, so there is no metrics in the post-fed state. What you see is disappearance of phase 3 MMCs and being replaced by a chaotic pattern where it's just a churning of the antrum. That would last by around 30-40 minutes and then it will come back to its normal phase 3 contractions. So that's why ideally we do 6 hours, 4 hours of fasting and then 2 hours of this thing. If we have done that and the post-fed state has not come back to its MMCs, that's usually considered as abnormal. But most of the time, the study that I have seen do not finish that 6 hour window. Rarely, but 6 hours is defined by various. It's a minimum required. Some of the international studies in US, they do an ambulatory study, that means 24-hour studies to really say. So post-fed is a bit more difficult in terms of there is absence of metrics, but what you just want to see is disappearance and then reappearance. That how it actually you say that it is there.
What is the time frames of how long you have to wait and you have to also?
As I said, 6 hours of fasting is minimum and 2 hours of post-fed. While doing the study, if you are able to see a phase 3, let's say an hour into the
phase.
So phase 3, if you can see a antegrade contraction going down, starting from top of a screen to downwards, and you can see 2 or 3 of them happening in an hour or so, then usually that means that the phase 3 contraction you can see is practically a normal study, and then you can directly go to a post-fed, part, and then that will shorten it up. But at least wait for 4 hours before you say that I'm not able to see a study. The issue is when you will be interpreting it, you have to compact, like for pH, you have to compact the whole 6 hours window into a 30 minutes window, identify where are the patterns, and then zoom into them before you analyze them. So eyeball it while you are doing the study for at least for an hour or so. If you can see phase 3 studies happening, that means that it's normal, and then you can go on to the post-fed state.
What about the pylorus part? Pyloric tone and pyloric model.
Pylorus will be in between that antrum and the duodenum. It is one of the ones which has the highest pressure. So 30-40 mm Hg. If it is normal, if it is very lax, pylorus is wide open, it will not show that contractions.
Yeah, this is basically.
How much we need to give that standard meal? How much ensure powder?
I think we need to give around 250 kilocalories. I think one scoop, it depends on what you're using, and you would just calculate it. I think an average commercially available ones would have around 400 grams and around 40 scoops, if I'm not wrong. So you can just calculate how much calories it makes. So roughly around 250 kilocalories, 200 kilocalories is good enough.
You have seen the recording what we have done, sir?
Yeah, I got the image of the position and the initial recording, so that looks okay. It looks normal. I mean, it looks like in fact, the image that you just was sent to me shows a phase 3 contraction right there itself, in the beginning itself. So probably it's what are the symptoms, or is it normal?
In the case of rheumatoid arthritis,
Okay.
our patient and has some bloating and then a lot of heartburn.
So in the one image itself, I can see a phase 3 contractions happening, but I'm not sure if you can see here. It may not be clear with you. Yeah. Probably it's not clear, but there is a phase 3 contraction in the beginning itself of the study of the image that I have. This one here. But the image is fine. At least the position is fine. So I think probably towards the end, we can see more contractions. The first image that was sent to me along with the floor image has one contraction, which looks like a phase 3 contraction. It is looking like an antegrade contraction going down.
More frequency.
We will record the session.
Once the study is done, you can send the file to me,
Yeah, sure.
analyze it again, and then I'll just send you the images once I've seen that. Thank you so much for having me again. Thank you so much. Thank you.
Any other questions? Thank you so much, sir. Thank you.
Thank you. Thank you so much. Thank you. And once again, I know
We'll be in touch with you more often.
Sure.
One question.
Yes, please.
If the patient has undergone a pyloric balloon dilatation, will the manometry be affected?
Yes, so if it's a pyloric that's not been done, it may not become in contact with the catheter that much. So you may not have those good contractions in the pylorus happening. So but I'll still encourage you to do it. Why I'm saying is because as of now, there is nothing like a London or Chicago or a standard way of doing this. Okay, so it's altogether a new investigation in a high resolution way using a water fused equipment. So whatever studies you do are part of literature. Eventually, this is what will be used to create those classifications. So as of now, there is nothing standard. We can't say, okay, do it. Theoretically, I assume that yes, if pylorus is dilated, it will not be in contact with the catheter. You may have a hypocontraction or a low pressures happening in that area. But just do it. There's no harm. There is no contraindication to it. We will just create more data.
And regarding artifacts from the blood vessels nearby, the comment on it.
From artifacts from around the antrum are less likely because by any other organ or any other blood vessel are less likely because that is very thick muscle, unlike the esophagus, where you're having. Only thing artifactual can be catheter movements, and that will be actually you will be if you look at the horizontal pattern of your study, you will see that wherever my pyloric ring was, it actually moved up and down. Or it was or when patient coughs or vomits, you will have a vertical contraction patterns. Those are clear artifacts. Anything antegrade, retrograde is usually a pressure moving up and down.
What's your take on this? Some people practice this EGG, and
we did a study on that, and I think problem is that EGG by definition. So in stomach, you are looking at gastric accommodation, you are looking at antral churning, and looking at gastric emptying. What EGG is probably only doing is studying the gastric accommodation. It's not looking at the emptying. And the way they tell us hypernormal and normal is a response. It's again an indirect way of measuring or telling you about the gastric emptying. Because if the gastric emptying is abnormal, gastric accommodation will also be abnormal. Right. So it's not a very good marker. It doesn't correlate very, very well with the clinical studies. But yes, me and Dr. Kapil, we had just presented at ISGCon this time in Amritsar the use of EGG to pick up patients where we might have done GPOM. But we have also done a gastric emptying study along with that. So it's still now.
Do you really recommend GPOM after EGG?
It's hard to. I mean, not only on EGG. I will probably.
That's what.
Do a gastric emptying before labeling somebody for GPOM.
Because many times people do recommend GPOM after EGG.
No. So as of now, I get a lot of referrals to do GPOM. I'll not do them until the gastric emptying is above 20% at least.
So based on ADM, what will be the findings where we really recommend GPO?
So if gastric emptying is abnormal, ADM is showing a hypernormal contractions, and there are some, at least there are some enteral contractions happening. I would want them to be there before I do a G point, because in case there is no enteral contractions, G might not work very well.
Thank you, sir. Thank you so much.
Thank you so much. Thank you. Thank you.
Informative and lucid. And we'll be in touch with you more often, trouble you more often.
Absolutely. Most welcome. Thank you so much.
Thank you, sir.